This slide we have already seen. I think this is very clear. This tells about the anatomy. Whenever we talk of any surgical thing, basic thing is to know about the anatomy. And this has got stomach has got an extensive blood supply. It is coming from the left gastric. It is coming from the splenic artery, giving rise to short gastric vessels, left gastroepiploic vessel. Then there is a common hepatic artery giving rise to gastroduodenal artery and giving rise to the right gastroepiploic vessel. So now these vessels, there are four vessels which are supplying extensively to the stomach. There is extensive vascular network inside the stomach, and extensive blood supply means extensive lymphatic drainage also. So lymphatic drainage will be again, there will be certain stations where the lymph nodes drain, and it is very important to know the lymphatic drainage once we are talking about malignancy, because whenever we are going to do a surgical dissection or surgical resection, we are going to remove the lymph nodes also. So this picture shows about the various lymph nodes which you are supposed to actually remember. There is a these are the levels of nodes which have been numbered. Now, what is this levels? Why there should be no confusion on this? In all GIT, lymph nodes are situated. Say, first lymph nodes are situated on the organ, whatever organ you are seeing. The blood vessels which are directly on the organ, they contain the lymph nodes. Then second tier of lymph nodes or second station of lymph nodes is the basic origin of the vessels, from where the vessels are arising. And then ultimately the lymph as it goes, level 3 is most of the times is the para-aortic and pre-aortic lymph nodes. So this is called not level, but these are the tiers of lymph nodes. Levels they have, this is basically done by Japanese people who have given it as level 1. Now see, this is level 1, this is level 2. Here is level 3, here is level 4, here is level 5, here is level 6. So these are first tier of lymph nodes which are situated just over the stomach. Then comes main vessels which are rising left gastric, splenic, and common hepatic. So nodes around these, they will be the 6 ended here. So 7, 8, 9, 10 will be here. And then further away toward the crus, and then we can go right up to 16, 15, 16 will be coming right on the uh, parietic, supramesenteric, and middle colic vessels, like here we have shown here in this picture. Now you see this picture, this is from a Japanese classification system. So they have got further classification of 1, 2, and then here it was supposed to be 3. So they have got so many three AB nodes up there, and 4 they have got 4, then multiple. So 4 further subclassified. Japanese people have actually dissected the stomach and most of the GITs so meticulously that they are able to diagnose the disease early. They are able to diagnose. If they diagnose early, they know which nodes will be involved in this particular disease, which has been diagnosed early, and they take out only those lymph nodes. They have studied the lymphatic drainage so thoroughly that they are able to dissect only the areas which are involved, which are required, and rest of the areas are not touched. So this is again lymph nodes, which you can just see. You can we initially we talked about level 1, 2, 3, again up to 16, and they've got a 1 to 6. They are situated just on the stomach. 7, 8, 9, 10, 11, 12. They will be on the vessels, and then going to superior mesenteric artery, middle colic. That means these are the various type of nodes, and this is just to revise. This is a mucosa, there is submucosa, muscles, and serosa. Four layers are there, and whenever disease in the stomach will start, most of the times we talk about the adenocarcinoma of stomach. And adenocarcinoma starts, adenocarcinoma will start in the mucous membrane here, and then it will infiltrate the submucosa, then the muscles. So it will give rise to various types of T stages that we have already discussed. Okay, this is. So now let's talk about the etiology. What is this carcinoma stomach? Carcinoma stomach etiology we've discussed is multifactorial. I told you previously also that whenever there is a malignancy, there are two things we have to remember. One is the sporadic thing which happens in a particular person in a particular generation, and it is not there previously, not it is not carried further. And then there can be genetic causes of malignancy. genetic which are heritable, which are coming in the families. These are two main causes of every malignancy. But whatever may be the cause of malignancy, may be an environmental infection, say a particular situation, maybe an infection like H. pylori infection. These infections, they ultimately lead to some genetic change because ultimately malignancy is an abnormal growth pattern, and abnormal growth is always regulated by the genetic material. So if genetic material is somehow defective, then only abnormal growth will occur. So that's why the etiology ultimately has some effect on the genetic material, which may be heritable or may not be heritable. In carcinoma stomach, Helicobacter pylori, we have read about it extensively. H. pylori is considered to be one of the major precancerous factors. And H. pylori infection will give rise to inflammation. Inflammation will give rise to metaplasia. Metaplasia will give rise to malignancy. So continuous irritation and then the same process. Other things, smoking is definitely associated with this CS stomach. Preserved foods containing a lot of nitrates or various preservatives, they are considered one important cause of malignancy of stomach. Smoked fish, people, especially the Japanese people, Hong Kong, in this area, people are very fond of taking smoked salmon. And smoked salmon that contains a lot of nitroso compounds, and they are also responsible for giving rise to carcinoma of stomach. That's why they say it's probably the incidence is high in those areas. Previous surgery is one thing that we say that vagotomy has been done in certain patients because of peptic ulcer. Gastrojejunal anastomosis has been done because of certain diseases, certain obstructions, benign causes. What they do, they will change the physiology. Once the physiology is changed, there will be reflux of bile into the stomach, and but continuous reflux of the bile into the stomach give rise to inflammation, metaplasia, and then dysplasia and malignancy. Then there are certain genetic causes which we will discuss in little detail. Pathology of CA stomach. Now this is we discussed. This is an adenocarcinoma. Adenocarcinoma of the stomach can be, say, intestinal type or diffuse type. These are two major things, which is called as Lauren classification. What is important to understand is intestinal type is the classical malignancy which develops anywhere in the GIT. Generally, it is an early disease. Generally, not always. Intestinal type of malignancies will develop as a small nodule or a small ulcer, infiltrate locally, cause local lymphatic involvement, then they become T4 lesions, go outside the stomach, and metastasize. Whereas diffuse malignancy will not be a small lesion at a particular place. Diffuse malignancy will be infiltrating whole of the stomach, and once it will infiltrate whole of the stomach, its spread will be different. It will systemic spread will be very fast, and it generally presents as an advanced malignancy. We can further, I think, yes, we can just see this is the intestinal and diffuse. We have tried to compare them. Intestinal malignancies are generally good prognosis. If we compare between the two, CA stomach is a poor prognostic disease. But out of this, if we divide into intestinal and diffuse, then intestinal type is basically associated with certain environmental factors. There is a gastric atrophy, there is intestinal metaplasia, men are more involved, it is more with age, classical factors which are seen in all malignancies. And it has a hematogenous spread, and these things we'll discuss later on, what is this microsatellite instability and all. Whereas diffuse type is generally a familial type, that means it has got a genetic basis right from the very beginning. So if there is a genetic basis even at your birth, then this disease is going to present early. So it has got a younger age group. Women are more likely to be involved. So it is a familial disease, so blood group type A is, and let's say, associated with most of the malignancies. These malignancies are poorly differentiated. They will be a well differentiated or moderately differentiated malignancies, whereas diffuse will be a poorly differentiated malignancy. Signet ring cells. Signet ring cells are where the cells, they contain a lot of mucin. Nucleus is put to one side, looks like a ring. So this is an indication of a very poor malignancy, which is undifferentiated, fast spreading, and poor prognosis. And this we'll discuss later. So now WHO is also classified. WHO also always doing something, trying to say. So they have also classified this disease into adenocarcinoma, which we are all we know that adenocarcinoma is a common malignancy in stomach. Then they say it can be adenosquamous, it can be squamous, it can be undifferentiated, it can be unclassified. So now these types will be towards the intestinal type of malignancy, whereas these types here they will be towards the diffuse type of malignancy. We discussed about Japanese people. That why we are talking of Japanese people, because they are trying to diagnose the disease very early because their incidence was very high. So they came up with a lot of say screening methods, and with this screening, they slowly thought that we will be diagnosing it as early as it is situated only in the mucous membrane. So this type of classifications are seen only with Japanese people. They will say type A, then type A will be just limited to the mucosa and protruding. Any malignancy which is protruding more to the outside is a relatively better malignancy. Any malignancy which is not protruding out, forming an ulcer like this and infiltrating inside is a poor prognostic malignancy. So this type they are very good things. They can just resect it. Even will tell something about say management. They are able to dissect it and just remove this much and do nothing else because it has not involved the submucous membrane. It is only in the mucosa, so lymphatic involvement is very less. So you may not do anything to the lymph nodes, and that's a very ideal situation to diagnose it very early and treat it. So this is a Japanese classification. Just for the sake of say understanding, we will not even remember it. But Japanese people define it. So how will they diagnose this? This we will discuss. And otherwise, which is we discussed about the Lauren classification, which was intestinal and diffuse. One more classification is the Borman's classification. Borman classification is on vision. How can we see on visual, say, impression, whether it's a protruded type of malignancy, or it's an ulcerated and little protrusion, or it is ulcerated with some protrusion but diffuse infiltration, or there is no ulceration but diffuse involvement. So out of these four types, this will be relatively better malignancy, but this is going to be ulcerated, and still some part is raised, maybe it's little worse than this but better otherwise. But this which is not ulcerated outside but infiltrating inside gives rise to a typical condition called as linitis plastica. Linitis plastica is when the disease has involved all the stomach layers, mucosa looks normal but muscles have been infiltrated, size of the stomach starts decreasing. Stomach is not in fact able to dilate, and that's why these their on endoscopy we will not be able to see anything, but the stomach will be non-distensible. We cannot biopsy anything, there is nothing here. So once we do a CT scan, we will find a very thick stomach wall. So very thick stomach wall, then we have to take a full thickness punch biopsy from here. Then only we can diagnose this condition. But by the time they are coming to us, they have a widespread lymphatic and say systemic malignancy also, which can be diagnosed by various other diagnostic modalities. Something, two, three things which we have already discussed actually, I think. Molecular pathology. Say, we talked about the genes. We have to remember three things in genetic problem in the CS stomach. Genes can be either mutated, that means normal gene is there but it is not working properly. It has gone to on a mutation, or a gene may be inactive. Inactive means these are basically tumor suppressor genes. And tumor suppressor genes, if they are inactive, then the tumor is going to be more say, aggressive, or tumor is going to present. So P53, you should remember it for all malignancies. Whatever you write, if P53 gene is inactive, P53 is a tumor suppressor gene. If it is not working, that means tumor suppression will not be there, and that patient is going to develop maybe multiple malignancies. Same is true for the BCL2 also. And sometimes a particular genetic product or a genetic expression will be overexpressed. Now, what is happening? Either it is mutated. So mutation is seen in APC or creatinine. You should just remember that intestinal type of malignancies, that means relatively better, have got APC mutation, whereas diffuse type of malignancies have got E cadherin mutation. And E cadherin is going to give rise to a very advanced or a disseminated disease. If certain things are overexpressed, what is the meaning of this? That there is a malignancy, we know the prognosis, we know the staging. What is the point of knowing this? That so these are certain enzymes, certain say markers, certain proteins which are expressed over there. Importance of knowing them today is that in a setting of an advanced disease, if a particular say, this ERB is present, overexpression is present, we have got a specific monoclonal antibody which we can give to treat these patients. We have got a specific monoclonal antibody in the form of Herceptin, which we give in CA breast. Same can be given here if there is overexpression. So now it has become a standard part that whenever we do a histopathology of stomach, we are going to ask that what is the ERB status, what is the HER2 status. If HER2 status is positive, then we will also give Herceptins in the post-operative treatment. Okay. Then there are certain things which we already know. Probably is the Lynch syndrome, which has got extensive metastasis malignancy in various organs, and they have got uh, microsatellite instability. They are basically the defective mismatch repair genes. Whenever there is a normal, say, uh, cell division, and a particular copy of DNA is copied to another copy, there is some defect, some DNA, some particular sequence is defective. Now that defective sequence, what happens is either it goes continues, if it is something is defective, it is not producing something, so some defect appears. But there are mismatch repair genes which generally detect immediately and delete that area and then correct it. So if their mismatch repair genes are not working, then at multiple places we can have multiple malignancies. So this HNPCC or hereditary non-polyposis colon cancer, which we will discuss later on, these patients have MMR repair genes are defective. They have got microsatellite instability. Lot of abnormal genetic material collect that is called as microsatellite instability, and this can also be known on histopathological examination and immunohistochemistry testing. So we can just revise this very fast that we have discussed is that etiology of this is multifactorial. There are pathological things, Lauren classification, and there can be intestinal, WHO classification, Japanese classification, Borman's classification. Molecular pathology is also there. Important thing that we have to understand is okay. So first let's discuss about the um, presentations, how these patients will present. Then we will come back to those things again. Clinical features of heavy malignancy I have discussed extensively with you is because malignancy is a solid mass. A solid mass is going to produce a mass effect. If it is going to obstruct a particular organ, it will obstruct its working, so it can produce vomiting, it can produce dysphagia. If now when dysphagia, if it is a gastroesophageal junction involvement, person will not be able to eat. If there is a obstruction at the pyloric end, then person will have vomitings. And if the disease is present in the liver, say, so there is metastasis in the liver, it will produce a lump in the abdomen, can be painful. If there is a bleeding inside that lump, it can be painful. So the presentation of the stomach malignancy will depend on so many factors. Where is the disease? What is the stage of the disease? What is the type of the disease? Type we discussed, it can be intestinal or the diffuse type. So these are 4 5 things presentations, common presentations. Five you should remember. Five most important is this fullness after meals, early satiety. And this fullness after meals, if it is why it will be there, now you probably can understand there is a diffuse type of disease. Some element of diffuse malignancy is always present. So that particular area of the stomach is not expanding because in stomach there is something called as receptive relaxation that is not there. It is not relaxing, so whenever person eats, he was previously taking say 4 chapatis, now not able to take even two. If I feel full after taking even one chapati, and if this particular symptom develops in an say 50 years male, 50 years, maybe 40, around 40 to 50, recent onset dyspepsia after 40 45 years, 40 45 years, this is a very important sign that you are supposed to act and you're supposed to find out what is happening. Then there can be obstructive lesions. Now, what is this obstructive? Obstructive disease. Disease is presenting in a protruded form, present at the gastroesophageal junction, will give rise to dysphagia. You will not be able to eat properly from the esophagus. Something will come down, food bolus will come down, but it will not be easy for it to go down. There are something called as we discussed while talking about esophagus, Sivert classification. What is this Sivert classification? Sivert classification will be that what is there? The diseases of the distal part of esophagus and proximal part of stomach. So now there is a confusion. What should we do to this? Whether it's an esophagus disease or it's a stomach disease. So if the disease is limited to the esophagus, say they used to say it is esophageal disease. If it is towards the stomach, they used to say it is stomach disease. And what if it is on the both sides? Then there is a confusion. So they've given it a very clear cut now differentiation. See, if you come to this slide, this is the gastroesophageal junction. Just a second. Hello, classroom, big classroom, classroom. So if there is a, this is the esophagus here. Now what they do is this to this area, which is 1 centimeter of esophagus and 5 centimeter of stomach. So this total area becomes 6 centimeter. This area they call as OG junction or esophagogastric junction. So disease which is presenting here is esophagus, treated like esophagus. Disease which is present here, 1 centimeter of esophagus, 5 centimeter of the stomach is Sibert type 2, and this is to be treated like esophagus only. And if it is present 5 centimeters of the stomach is spared and then the disease is present, then it's in gastric disease. So it is to be treated like CA stomach. So now you can understand if there is a disease present in this area, OG junction, the primary presentation will be in the form of dysphagia. So this now let's come back. Obstructive dysphagia. If the same obstruction is towards the pyloric end, person will be able to eat in, say normally in the morning, he will feel little fullness towards the afternoon, and toward evening he will have a say vomiting. Then comes bleeding. If it's an ulcer which bleeds, it will be obviously a bleeding can be a presentation which can present as melena, which we have discussed thoroughly. They can present as metastatic or non-metastatic diseases also. What is this metastatic disease? Metastatic disease, it can present as a supraclavicular lymph node, which we call as Virchow's node or Trousier's node, Trozier sign. Can present as a periumbilical node. These are metastatic presentations, advanced disease, Sister Mary Joseph nodule. Can present as Krukenberg's tumor, a tumor which has fallen down from the stomach on an fertile ovary and then grown there. So it becomes a Krukenberg's tumor. Or they can the same cells which can fall down from the stomach and say sit in the pelvis, and once you do a rectal examination can feel as an extrarectal mass which you call as Blummer shelf. So these are presentations of CA stomach in an advanced setting. They can present in a non-metastatic form. That means a person is presenting with deep venous thrombosis, which is happening, superficial venous thrombosis, fleeting thrombosis at various places, and this thrombosis is not one is not able to know the cause of it. And once you investigate, you find that there is a lesion in the stomach. And sometimes these patients can present insidious, means there is a present they develop a you are not able to see anything. They are presenting just with loss of weight, loss of appetite, and there is no other symptom. Now, when this will develop, suppose the disease is present here in the body of the stomach. So there is no obstruction. It is not ulcerated, so there is no bleeding, and person is able to eat, and disease is increasing, 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 and suddenly, one day, once it becomes perforation or it bleeds massively, you investigate and you find a big mass in the stomach. So it's an insidious onset. Sometimes there is small bleeding occurring, and you are not able to find anything in a person. You are just investigating, and you suddenly see a big mass in the stomach. There were no symptoms. Asymptomatic patient came to you with simply anemia. You were investigating anemia, and once you were thinking that now I should do an endoscopy, and then you find there is a big mass inside. When an ultrasound was suggestive of some mass lesion, you did an endoscopy, found a lesion inside. That's called an insidious type of presentation. So, anemia, anorexia, asthenia is one presentation. Lump A palpable lump can be another clinical presentation. Gastric outlet obstruction or dysphagia can be another. Bleeding in the form of melena mostly. Sometimes maybe hematemesis can be another presentation. Sometimes these may perforate or metastasis we have discussed already. So now these tumors we can stage them. What is the importance of staging? We have discussed so many times. We want to stage the disease so that we know what is the best treatment for this patient, what is the prognosis of this patient, so that we can tell this that this is going to happen to you, and we have got various treatment options at various stages, so we know how extensive the disease is. And say the tumor, which can be there is no evidence of primary tumor, or there is a small lesion, T1 lesion. Now we have discussed about this lesions in this breast. In the breast, we were talking about the size of the tumor. In intestine, we don't talk of the size, but what we say is that there is a lesion which is infiltrating into which layer. This we have discussed frequently. So T1 lesion, T1A, T1B. T1 lesion is limited to the mucosa and submucosa. That's it. Once it comes to the muscle, it becomes a T2 lesion. It infiltrates the muscles and becomes subserosal, becomes a T3 lesion. Perforates, becomes a T4 lesion. This is very important to understand about the nodes status here. Now we have discussed about nodes 1 to 16, so many regions. Now what we talk is that 1 to 2 nodes are involved. Out of these 16, only 2 nodes are involved. That means you are removing all of them. Then only you can say only 2 are involved. If you remove only 2 and say none is involved, that is not the point. You have to remove all of them, and then only you can say that yes, I have removed. How many nodes